Hey everyone, we've got another heart here today. This is heart number 70 in our collection. The heart would have sat in the chest roughly like this, anterior surface up here, posterior surface towards the turntable, superior head up here, inferior legs down here, left over here, right over here. So let's start off by first identifying what looks like the right atrial appendage externally. And here we have an appendage that looks triangular, pyramidal, or broad-based. So we'll go ahead and start there. So we'll open up that appendage. And when we open up that appendage, we do see that there are pectinate muscles that spill outside the confines of the appendage themselves, consistent with a morphologic right atrial appendage. Now, when we take a look at the oval window or the oval fossa here, we see that there does seem to be a little bit of an intraatrial communication here. So there is a oval fossa type atrial septal defect. As we move down, we find the coronary sinus, and we find the tendon of Todaro here. And immediately we see that there's another shunt here as well, but this is an atrioventricular septal defect, and this is the atrial level shunt of the atrioventricular septal defect. It's an important distinction to say this is not a true atrial septal defect. True deficiencies in the actual atrial septum occur here in the oval fossa and the vestibular spine area. This is truly an atrioventricular septal defect, which will have potentially both an atrial and ventricular component. And here we see the atrial component of the atrioventricular septal defect. Now that we've found this, we can assume that there's going to be a common atrioventricular junction, which it does appear is the case in this heart. And we'll kind of turn our attention back to the coronary sinus because we'll try to identify where the triangle of Koch would sit. And remember, the triangle of Koch in the heart is usually bounded by the coronary sinus, the tendon of Todaro, and then the right-sided AV valve. When we try to draw the triangle of Koch in the normal heart, the tendon of Todaro usually extends all the way down here. This leaflet will extend all the way over here with an AV node that usually would sit somewhere here. In this heart, obviously, that's not possible because the AV node can't suspend itself in midair, and there is an atrioventricular septal defect here. So in fact, this is why the AV node is displaced in the setting of an atrioventricular septal defect, and we would expect that the AV node would be right here. So very close to the coronary sinus. Here we find one of the components of the right-sided atrioventricular valve. And here we find another component of the right side of the atrioventricular valve. As we look down on this common atrioventricular valve, we do see that the superior bridging leaflet has two components, a left component and a right component. The left-sided component does have connections to the crest of the ventricular septum, which is right here. So here is the left-sided component of the common atrioventricular valve, and here it has connections to the crest of the ventricular septum. And both the left and right components of the superior bridging leaflet are equal in size, making this consistent with what most people would call a Rastelli A classification. Here we see the inferior bridging leaflet. The inferior bridging leaflet courses through the atrioventricular septal defect. As you can see, does the superior bridging leaflet as well. The right anterior and right inferior leaflets are here as well. When we look at the ventricle here, this ventricle does have a septomarginal trabeculation right here, consistent with a morphologic right ventricle. Remember, there is a common atrioventricular valve in this heart because this is an atrioventricular septal defect, and thus we can't use the AV valves to help guide us as to what morphology this ventricle is. And so the septomarginal trabeculation, easily identified here, gives us a nice signal that this, in fact, is a morphologic right ventricle. And as we look into the outflow of the right ventricle here, we do find the right-sided superior bridging leaflet here as well. And we can see some of the connections of the left-sided superior bridging leaflet here to the crest of the septum. We see that the ventricular septum isn't indeed intact. We find our first semilunar valve here, and this semilunar valve does have 3 leaflets as well as 3 sinuses, making this consistent with the morphologic pulmonary valve. And this would have been the pulmonary trunk, which is now transected and would have given rise to the right and left branch pulmonary arteries. If we go ahead and flip this heart to the back, here's the left atrial appendage externally. We'll now open and expose this atrium here. This atrium is smooth-walled, consistent with a morphologic left atrium. Here's the orifice to the left atrial appendage, and you can see that all of the pectinate muscles of this appendage are confined within the appendage itself. They do not spill outside into the vestibule of the atrium, consistent with a morphologic left atrium. Here are the horns of the oval window, the horns of the oval fossa. And remember, there was a flap-like defect in the oval fossa. Now we can see the atrioventricular septal defect from this side. We can appreciate the atrial level shunt that this child would have had. Here is the left-sided component of the superior bridging leaflet. We can see that course through into the atrioventricular septal defect. We've already noted its connections to the crest of the ventricular septum, which can also be appreciated here. So here's the crest of the ventricular septum, and there are direct connections of this left-sided superior bridging leaflet to the crest of the ventricular septum here. Once again, consistent with a Rastelli A. Here we can see the inferior bridging leaflet coursing over, and then what appears to be a left mural leaflet that has been transected. You can also appreciate that in this heart, this is primarily an atrial level shunt. There really isn't a ventricular level shunt here below the level of the common atrioventricular valve. So this is an AVSD with an atrial level shunt only. Here we find another ventricle, fine crisscross trabeculations consistent with a morphologic left ventricle. And then we'll flip this over and go into the outflow tract here. Once again, we can also appreciate the superior bridging leaflet here. We now come across another semilunar valve. This one also has 3 leaflets, 1, 2, 3, with 3 sinuses. There's also coronary arteries that are arising from within 2 of these sinuses. So here is one of those coronary ostia. So they're all consistent with a morphologic aortic valve. And here is the ascending aorta, and the transverse aorta is here, and then the descending aorta has been transected, and we can see the head and neck vessels here. Obviously, an interesting phenomenon occurs in the setting of atrioventricular septal defect, since there aren't 2 atrioventricular valves for the aorta to be wedged between. The aorta actually is sprung forward, and that leads to a discrepancy in the length of the inlet component of the left ventricle versus the length of the outlet component of the left ventricle, with the outlet component being longer than the inlet component. This results in the so-called gooseneck deformity, and is what people also refer to as the unwedging or the springing forward of the aorta and the left ventricular outflow tract. So a specimen here with an atrioventricular septal defect with primarily an atrial level shunt. Here with a superior bridging leaflet that has a left and right component that have basically equal size, and with direct connections of the left-sided component of the superior bridging leaflet to the crest of the ventricular septum, making this consistent with the Rastelli A.